he noticed that the endo had progressed so badly. There was so much scar tissue as well in the uterus, and he said the fallopian tubes were blocked. So it was so bad that he said the only way I could try is to actually through IVF.
I was told by a private gynaecologist that I wouldn't have any more children, but I did. Yeah, and it just seemed to have got easier, I think. I've been pretty much pain-free for a good few years now.
I was told by one pregnant doctor, you'll have to start trying when you're 26 if you want any chance of having children by the time you're 30, because you're going to miscarry a lot.
In 2011, I had my first miscarriage, and then end of 2012, I had my first laparoscopy when they confirmed that it was endometriosis. Then I had a miscarriage in 2013 again, and another laparoscopy in 2014.
I was told that I had a window of up to maximum of 5 years to have a child. I was 20.
What I want to look at today is, in particular, ovarian endometriosis and how that relates to fertility. And ovarian endometriosis is quite unique because it's the only form of endometriosis where we're able to make a preoperative diagnosis with a fair degree of certainty. What you're looking at on the screen there is an endometrioma. That's a cyst growing within the ovary, and it's full of old chocolatey blood, hence called a chocolate cyst. And these can be diagnosed very accurately by ultrasound. So let's take a look at some of the evidence relating to the treatment of endometriomas. And firstly, what are the options? Well, you can use medical management, surgical management. We can measure pain and fertility outcomes. We need to know a bit about recurrence. And in particular, I'm going to focus on the impact of ovarian surgery on ovarian function in the future. If you use medical treatment to treat an endometrioma, there's no question you can reduce the size of a cyst, but 6 months later it will be back to its original size. And all of these historical studies looking at the listed drugs versus placebo show no increase in the chance of pregnancy after a course of treatment. In fact, some of the drugs actually reduce your chance of pregnancy after a course of treatment. So if you go to a doctor who says, let's put you on this drug or that drug to help your fertility, you really need to find another doctor. What about surgical treatment? We can drain the cyst, we can open up the cyst and ablate or destroy the inner active lining of the cyst, or we can strip the whole cyst out. Ultrasound-guided drainage is an option. It's not always easy because the blood content of the cyst is often very tenacious, and you get an extremely high recurrence rate and a risk of introducing infection into the ovary. I'll talk more about that later. Or you can drain a cyst laparoscopically, and in this study by Versolini, an Italian gynaecologist, he drained 33 cysts laparoscopically with a recurrence rate of 100%. So that's not really making much headway either. So really, the true options are either ablating the inner cyst lining or stripping the whole cyst out. And these are the only two randomized studies in the literature that looks at ablation versus excision or stripping and the subsequent pregnancy rates. And they both have very similar figures. Pregnancy rate of 23% or 23% after ablation versus 66 or 59% after excision. So clearly stripping the cyst out is advantageous. And if you look at Alborzi's data, that's the second study I showed you, graphed out, you can see that over a 12-month period after excision of the cyst, about 50% of people are going to achieve a pregnancy, which is good. What about recurrence? And in reality, we see about a 10% per annum recurrence rate after treating ovarian endometriosis. And all of these comparative studies comparing ablation with excision, all favour, once again, excision as the method with the lowest recurrence rate. This was published as a Cochrane review in 2005. Cochrane review is where a panel of doctors review the literature on the subject and come up with some guidelines, and Cochrane review concluded that there was good evidence that excisional surgery for endometriomas provides a more favourable outcome, especially with regard to subsequent pregnancy. This image of massive bilateral endometriomas was taken from a 21-year-old girl, and her name is Chloe, and she has no symptoms whatsoever, and only came to notice because her older sister came to me with infertility and was found to have quite severe endometriosis when I did a laparoscopy. And she made her young sister come along and get checked out. And Chloe had these huge bilateral endometriomas, which leads me on to this data, which I find absolutely fascinating. Thomas Tehoog is a Belgian gynaecologist who incidentally is possibly going to be settling in Sydney in the near future, which would be a fantastic thing. He's been a very active researcher, and he took 221 women who all regarded themselves as being asymptomatic. They all had infertility of at least 12 months duration. They were all ovulating, and they had partners with good sperm. And he laparoscoped them all. 47% of them had endometriosis, which is really, I find, and I find this in my own practice too. We have a lot of asymptomatic women who often have quite bad endometriosis. You can see in this group that 40% of those with the disease had stage 3 or stage 4 disease. I want to move on and focus really on fertility, and this is a male frigate bird doing his best to attract a mate. If you're wondering about the wildlife, my wife Hilary and I had a trip a couple of years back to the Galapagos Islands, and I always like to take the opportunity to show off a few of my photographs. What about ovarian endometriosis and infertility? How important is that to most women? Well, if you ask these women who sit in front of you, are you concerned about your future fertility? They turn to you and almost universally say yes. In fact, it's usually when the tears start. What about treatment? And in reality, what happens in this country, and for that matter all around the world, is that if you have infertility and you get referred to an IVF doctor, you get IVF, or assisted reproduction. And if you get referred to a gynaecological surgeon, guess what? You get an operation. And there's probably a bit more to it than the pure chance of who your GP happens to refer you to. This photo was not photoshopped, it was taken real time on an island in the Galapagos, and it just reminds me about the two approaches we have, surgery and IVF, good old-fashioned surgery and sexy new IVF. What's the best approach? Now, this is classically what or how I used to manage a patient with an endometrioma. I would do a laparoscopy and I'd treat their endometriosis, restore their anatomy as much as possible to normal, and send them away to attempt pregnancy on their own. And if they achieved a pregnancy, that's the smiley face, and if they didn't, then they moved on to IVF. And of course you short-circuit that if they've got poor partners or they've got blocked tubes. But not everybody wants to have an operation, and so those who elected to go down a primary IVF path, I would certainly encourage them to reconsider having a laparoscopy if they had a couple of failed cycles, for the reasons I've shown you already. And so we start to see guidelines coming out. These are American Society of Reproductive Medicine guidelines recommending surgery for an endometrioma over 3 centimetres, especially to improve spontaneous fertility, and quite erroneously, possibly to improve their ovarian response in the event of IVF, and that's where I'm heading. And then we see the European Society for Human Reproduction and Embryology guidelines in 2008, And they say much the same thing. Endometriomas over 3 centimetres deserve surgery, but for the first time you're seeing a few warning signs that the woman should be counselled regarding the risk of reduced ovarian function, and you should reconsider surgery if she's had ovarian surgery before, because ovaries in particular don't like repeat surgery. And it started to become apparent that excision of endometriomas certainly may impact on ovarian function. You certainly get a reduction in ovarian volume, and the electrosurgery that you use to stop bleeding can damage the ovary as well. And we became quite acutely aware of this potential decrease in ovarian function back in about 2004. And what you're looking at there is a microscopic slice through an endometrioma, and this is the active inner layer, and there's a layer of fibrosis or fibrous tissue around the outside of that, and this is a layer of ovarian tissue. So you're actually removing ovarian tissue when you strip out these cysts. Again, here's the active layer, here's quite a thin layer of fibrosis, and here's a really, really thick layer of ovarian tissue, and this is a primordial follicle, or a developing egg. And we measured the percentage of the specimen that was ovarian tissue versus endometriotic cyst wall, and you can see it ranges from 10% up to 95% of the specimen. So in some of these women were really taking out a lot of ovarian tissue. There have been two things in recent times that have changed my practice, and the first is the ability to measure a hormone called AMH, or anti-Müllerian hormone. AMH is a hormone that's produced by the granulosa cells that surround the egg, and hence it's an indirect measure of the total egg numbers that a woman has in the ovary. It's quite a convenient test. You can do it at any time of the cycle, but most importantly, you must understand it's not giving you information about a person's natural fertility. It's giving you information about how that ovary is going to respond to stimulation in an IVF setting. And this was the form the graph that we were using early back in 2009 when it became available, and you can see the median AMH level versus age, and of course as you grow older and you're using up eggs, your AMH level is slowly coming down. And you have 90% of the population under this line. Polycystic ovarian patients tend to run very high AMH levels, and you have 10% of the population under this line. So we're getting a handle on the variable egg numbers that a woman may have. And this is a plot of the number of eggs retrieved in an IVF cycle versus AMH. And it was never designed, but roughly speaking, the AMH level equates to the sort of egg numbers that you'll get. So you have an AMH of 10, you're probably going to get around 8 to 10 eggs. And so it's a really useful indication of what ovarian response is going to be like. I'd like to tell you that this doesn't happen to my patients because I do really good surgery and I'm very careful, but I can't say that because the impact on AMH levels and ovarian function is independent of the surgical experience. So we started measuring pre- and post-operative AMH levels in women having endometriomas removed. Look at on the right down here, the percentage fall in AMH after taking out an endometrioma. We were sort of a bit horrified by that. And when we got up to about 35 patients, this is a graph of the drop once again in AMH levels. The red lines are the case when you operate on both ovaries, and the average AMH fall was about 60 to 70%. And surprisingly to me, the blue lines are when you operate on only one ovary, and the AMH fall is still around 50%. The second thing that has changed my practice in a big way is the ability to freeze not only embryos, which has been happening for ages, but also being able to freeze eggs. Vitrification is a process where the eggs are snap frozen. Unlike the old method where they were cooled down slowly, there will almost invariably be irreparable damage to the egg using that technique, but not so with vitrification. This is some data about pregnancy rates when you transfer a fresh embryo versus transfer an embryo that's previously been frozen, then thawed out for the transfer. And there's no significant difference between fresh embryos and frozen embryos. You might say, oh, there's a bit of a trend to a worse outcome, but just remember from this data that the best embryo has been put back already. So this embryo is the second best one. There's a trial going on at Gynaea. Well, let me say that there's discussion all around the world that in fact pregnancy rates when you use the best embryo may in fact be better from a frozen embryo than a fresh one. And there's a trial going on at Gynaea at the moment to allocate randomly people into fresh transfers versus elective freezing. If you do genetic testing on embryos and weed out the abnormal ones, you would expect an improvement in pregnancy rates, and indeed you see that. But if you do the modelling, the actual pregnancy rate is higher than you would predict. And perhaps that is because when you do genetic testing, you have to freeze all of the embryos while you're waiting for the test results to come back. There's also evidence that you get less pregnancy complications, especially placental abruption or bleeding or premature separation of the placenta when you use previously frozen embryos. And David Healy's work, the late David Healy from down in Monash, great guy, has demonstrated a reduction in the fetal abnormality rate when you use previously frozen embryos. So the bottom line there is that I don't think you're being disadvantaged by freezing embryos. What about egg freezing? And there's still a perception that egg freezing is experimental. It's not. There's a lot of data coming out, especially from Italy and Spain, because in those countries, if you're going through IVF, you can only make 3 embryos by law. So if you collect 12 eggs, you make your 3 embryos and you freeze the other eggs. And when you want to have another baby, you come back and use those eggs that have been frozen. So we're actually getting a lot of data, and you can see the survival rate around 85% when you thaw them. Really good fertilisation rates. You don't see better than that with fresh IVF. Half of those fertilised develop into blastocyst or day 5 embryo, which is the conventional day we transfer, and you get a 30% live birth rate per embryo transfer. That's not experimental data, that's the real thing. And so my algorithm has changed. If I have a woman with an endometrioma, I check her ovarian reserve. If she's got a higher than average AMH, I go ahead with surgery and then send her away to try and get pregnant all on her own. If her AMH is average or lower, I would put to her that perhaps we should freeze some embryos before she has surgery. And if a patient is not wanting to be immediately pregnant, but is concerned about future fertility, same deal. A consideration is to freeze embryos before she has the ovarian surgery, and if she doesn't have a partner, and this raises a few social issues at times, then she could freeze eggs so that she's able to use those eggs with any future partner. It's been a real surprise to me, but when you show women with endometriomas this data and you suggest freezing either embryos or eggs, they jump at the chance. There's still a lot of publications like this that are implying that in vitro fertilisation will get around the problem of infertility anyway, and it's just as good to go straight to IVF. But when you really look carefully, look at the conclusion, with the exception of patients with endometriomas. So they're the tough ones. What about the risk of getting infection when you drain off an endometrioma? We haven't got much data about that. This is one patient from 95 that said when you use ultrasound-guided drainage, you're looking at an infection rate of just over 1%. And that's very different to our experience. We do 4,500 IVF cycles per annum at Gynae, and we would have 1 or 2 women develop ovarian infection over that number of cycles. So that's putting the incidence at a very, very low rate. It is, however, my worst nightmare to be creating embryos or eggs for storage and to have a woman develop ovarian infection, because it's a particularly nasty problem. It hasn't happened to me. I do take a lot of steps to try to avoid possible infection, including really prepping out the vagina well, as you would for any surgery. Avoid sticking a needle into the endometrioma, and certainly giving them good antibiotic cover during the procedure. So I hope if we look back over some of these things that might impact or influence the way you manage these women in their quest to take home the baby. Thank you very much.
So in terms of the history of endometriosis, this is probably a condition that's been going around for thousands and thousands of years. And certainly in references in earlier works, there's been references in one form or another for literally thousands of years. And it's the same sort of disease. In the modern form, Sampson was a surgeon who really identified it in the late 1800s. And they noticed at laparotomies, when they made big holes in people, big chocolate cysts and the organs being fused together and palpable nodules within the vagina. Clearly they were sort of extreme forms of the disease, but it's almost certain that this disease has been around for a very long time. With the advent of the small chip sort of cameras and the capacity to do a laparoscopy in the sort of the 1950s and 60s, and more so into the 70s, where laparoscopy became more and more popularised, we became able to visualise it more. So it may have felt as though there were more cases, and we're not quite sure if it's getting increased in terms of the numbers of cases we're seeing, or whether it's more easily to diagnose it with these small camera systems that we have now. But there's no doubt it's been around for a very long time. As we know, people in this country will have puberty or go through, have their first menses around about 10 to 12, but increasingly that number's decreasing, so that in the US at the moment, there's something like 25% of people will have their first period before the age of 10. And clearly at that age, it's probably inappropriate to get pregnant, but nature doesn't necessarily think that way. And for our purposes in our society, it's reasonably acceptable to be pregnant sort of any time from sort of 18 to 19 onwards, but you need to recall that peak fertility is around about 22, 23, and it's fairly constant in terms of your fertility until roughly the age of 35. And from about 35, there's a much more increased decline, and by the time you hit 40, your natural fertility is in free fall. And that has sort of major considerations, particularly if you're contemplating 2 or 3 children. And there's a large number of people in Australia, in particular, who appear to be putting off getting pregnant, so that the average age for the first delivery is heading into the high 20s, and there's quite a number of people who will delay child rearing into their 30s, mid and late sort of 30s in particular, and that poses a particular problem because fertility at that point is significantly compromised. So roughly speaking, at the age of 35, if 4 of you are sitting around having a cup of coffee, 1 of you won't get pregnant naturally, which is a reasonably big deal, and I think for an awful lot of people I haven't quite appreciated the extent of that decline. It becomes much more important when we consider endometriosis additional to that, because endometriosis of itself has a particular problem in terms of fertility. The younger you are, the less of an issue it is, but if you delay things from the age, particularly from your 30s onwards, that becomes a particular problem. And in your late 30s in particular, it's a big issue. So how does endometriosis create problems with fertility? We're not really sure. There's a number of theories about it. But just to go back a little step, what it does mean is that endometriosis has the effect of adding years onto your age, your fertility age, so that at the age of 35 you may actually have more of an age closer to 37 or even 38, or possibly older if you have endometriosis, particularly if it's the more severe sort of form. So how does endometriosis affect fertility? We're not exactly sure, but we know there's a number of possible mechanisms and there's a number of theories. Initially, when we talk about endometriosis, it's important to think some of the new concepts that people are thinking about. So perhaps if I'd use this diagram here, you'd all appreciate that endometriosis is the presence of the endometrium which grows inside the uterus and that you would shed once a month, growing on the outside of the uterus, on the various ligaments and the organs, predominantly within the abdominal cavity and usually within the pelvis. And these deposits are hormonally responsive, they swell, bleed, and you get a degree of underlying fibrosis and scarring. So you get very much a sort of an iceberg effect. So what you see on the surface may not reflect the extent of disease underneath. That's sort of the definition of endometriosis, but that's not the only thing that's going on. So we know that if you have this condition, you'll have a number of other things occurring as well. You'll have changes in terms of the local peritoneum, so the fluid that is bathing the intra-abdominal and pelvic organs is going to be different to normal people, so it's abnormal. We know there's changes as well in the normal uterus, so what looks like a normal uterus on imaging and even under normal histological analysis. At a research level, there's changes and abnormalities between the myometrium and the endometrium, which is quite abnormal compared to the normal situation. It's also probable that there's changes in the ovaries of eggs of people with endometriosis. So there's some interesting studies. One, for example, we know of where if you take eggs from people with endometriosis and you donate those eggs to somebody who does not have endometriosis, those pregnancies are less successful than if you do it the other direction. So the concept is that it may be that there's something empirically wrong or different with the eggs of those individuals with endometriosis. And additionally, there's changes in terms of the whole immune system, and there's an association with autoimmune problems which we don't particularly well understand. But suffice it to say, what it means is that the older definition of endometriosis just involving some areas of abnormality outside the uterus is not the whole story. There's a number of other issues. So there's these areas which are inflammatory, there's changes in the uterus, there's possibly changes in the ovaries, and there's possibly changes in the immune system. And all of those areas can have an impact in terms of conceiving. We're fairly sure that these normal deposits that people have, or should I say abnormal endometriotic deposits, are inflammatory, and when you look at them surgically they can have the consistency of concrete. So there's a very acute inflammatory reaction. We see sort of changes with adhesions, other inflammatory sort of markers. And as I say, the fluid that bathes the abdominal organs is different in these people compared to the normal individual. And it's probable these proteins, these fluids, these immune modulators, immune factors have an impact on eggs, egg quality, sperm quality, fertilisation, and then implantation. And so we can see there's really a large number of ways that endometriosis potentially is going to impact on getting pregnant. What can you do about it? Probably from what I was saying before, you can probably never completely get rid of endometriosis. So from a surgical perspective, I think you'll hear elsewhere in the meeting that the best idea with this sort of iceberg concept of endometriosis is to try and remove all of the iceberg rather than simply remove the top. And if you can do that, you can dramatically decrease the inflammatory load and potentially this, at least part of the immune effect on eggs, sperm, embryos, and possibly implantation because of some of these other factors. Even if you do all those things and you remove all of the endometriosis that you can see, there's still probably other changes, there's probably other factors occurring. So that ideally you want to optimise the removal of the endometriosis, and then hopefully you don't want age to be a major factor. So that's why you really want to be under 35, ideally, to try and conceive if you can. The other things that you can do, it really depends on a sort of an individual basis as to what would be the preferred way of running things. So surgery is appropriate for some people, but not all people. Medical management in terms of hormones and things is entirely useful, and we use it a lot in terms of an adjunct and ancillary way of managing people with endometriosis. But from a fertility perspective, unfortunately, all of the medical treatments are largely contraceptive, so that's not really going to help. In the setting where you can conceive after the pregnancy and after you're finished with your child rearing, it's probably optimal to utilise some form of progestogen or pregnancy type support. So from an ideal situation, endometriosis wouldn't be a problem if you got pregnant and stayed pregnant, if you had 10, 20 pregnancies. That's what used to happen, of course, 100 years ago. But nowadays, people limiting their children, their children's numbers at least to say 2 or 3 for the most part, and that leaves a large number of years where there's ongoing issues. And if you want to space children, then it would be entirely appropriate to use some of those progestogenic pregnancy type agents in the middle. So one of the interesting theories that's come about recently, and at this point in time we really don't know what causes endometriosis, and we really don't even know exactly what it is. It does have a number of changes other than just the endometriosis being outside the uterus, and one of the fundamental changes is within the uterus itself, between the lining of the uterus, the endometrium, and the muscle, the myometrium. And at the myometrial endometrial interface, there's a number of changes we can see at a research level. So there's one concept I think is very important to understand, both from the question of fertility, but also from the question of managing this condition. Historically, as we've been talking, and as you've heard during the day, endometriosis is where the lining grows on the outside of the uterus. But as I've elaborated, it's not that simple. There's other changes as well. So there's changes outside the uterus, actually within the uterus, even though the uterus looks normal, possibly in the ovaries, even though the ovaries may look normal, and possibly also in the immune system. And we know from historical sort of situation that if you were to get pregnant and stay pregnant, which really was the lot of women perhaps 100 years ago and for the preceding sort of thousands of years, where it was not uncommon to have 10, 12, 15 pregnancies. And in those days, endometriosis wasn't such a big deal. It's become a problem when you don't get pregnant. And the modern woman who has incessant ovulatory cycles for years on end, that's probably not normal from an evolutionary perspective. So normal was to be pregnant or breastfeeding during the reproductive years. So what that means is that in terms of managing endometriosis, the preferred option is if you do need surgery, to try and remove all of the disease as far as possible, but then back it up with some form of additional treatment, ideally pregnancy, and then sort of staying pregnant for 10 or 20 pregnancies, but in the absence of that, using something like Mirena, which is an IUD that sits inside the uterus and secretes a progestogen, and it sort of acts like a pseudo-pregnancy, or other types of progestogens, Implanon, this new drug that Endoactive has been good enough to get into the country, Visane, acts in that sort of category, and the contraceptive pill. But the point is that purely doing a laparoscopy alone, and especially if you're just burning the top of the iceberg, is not sufficient therapy. In an ideal world, you want to remove all of the endometriosis and then either get pregnant or be in some sort of pregnancy-like state, probably for some extended period of time, and preferably until you go through the menopause.